So our next speaker is well known to many of us in the room, Dr. Simon Erickson, who's a staff specialist in paediatric critical care at the Perth Children's Hospital in Western Australia. He's immediate past chair of the Paediatric Study Group of ANZICS, and his work-related interests are in clinical research, use of echocardiography in paed ICU, and acute care teaching. Thank you, Simon.
Thanks very much, Tina. So I'm going to present the sedation practice in paediatric intensive care evaluation, or Baby Spice pilot study. Debbie Long and I were co-collaborators on this, and this was a study that was performed by the ANZICS Paediatric Study Group, and I'll acknowledge all the contributors at the end. So as far as conflicts of interest go, the study did have some support from industry, an unrestricted grant from Hospira and Pfizer, and the Perth Children's Hospital Foundation grant, which has allowed us to do this study. So critically ill children who are mechanically ventilated usually receive analgesia and sedation for comfort and safety, and opioids and benzodiazepines are the most frequently administered drugs. Current approaches are often inadequate. Sedation-related adverse events are common, in particular over-sedation. And we showed in our observational data that deep sedation occurred in up to 75% of intubated children. Early goal-directed sedation using dexmedetomidine as the primary sedative may provide more targeted sedation with less adverse effects. Dexmedetomidine is an alpha-2 agonist with sedative, anxiolytic, sympatholytic, and analgesic properties. And although not TGA approved for paediatric use, it's become widely used both as a sedative and to treat and prevent withdrawal in paediatric intensive care. And however, its efficacy and safety haven't been evaluated in a large, rigorous RCT. So in the context of this study, as you know, there's 7 PICUs in the Australasian region, over 8,000 admissions per year, and 40% of those patients approximately are ventilated. So we performed this study in 6 of the 7 PICUs. Michael Young was the DSMB chair in South Australia, and so they didn't take part in the study, but all the other units took part in the study. So the objective was to assess the feasibility of conducting a randomised trial comparing early goal-directed sedation with dexmedetomidine as the primary sedative versus standard sedation in critically ill children. And our primary outcomes were really feasibility, so the screening and recruitment, timely randomisation and drug administration, and protocol adherence. And we had a number of secondary clinical outcomes. Firstly, the level of sedation, duration of ventilation, PICU and hospital length of stay, and adverse effects. So it was an open-label pilot randomised control trial conducted in 6 PICUs, and the inclusion criteria were patients that were mechanically ventilated with an endotracheal tube that had been intubated for less than 12 hours, and the treating clinician believed that the patient required immediate and ongoing sedation, and the patient was expected to remain intubated for at least 24 hours after enrolment. It was a block randomised with concealed envelopes. We compared the 2 groups with equal randomisation. Data was put onto REDCap online data entry. We performed the state behavioural scale sedation score every 4 hours in patient, and the goal was to try and aim for safe light sedation with a SBS score of -1, 0 or +1, and patients were followed for either 14 days or until ICU discharge, and stats were descriptive and univariable. There were a number of exclusions. Obviously, we excluded patients 16 years and older, and the most important exclusion was the exclusion of acute and chronic primary brain lesions. We felt this would impair assessment as we were trying to keep the patients relatively lightly sedated. We also excluded burn injuries in patients that would require frequent neuromuscular blocking agents, given the goal of safe light sedation. And the other exclusions were all self-explanatory: cardiovascular instability with the use of dexmedetomidine, and end-stage type patients or patients that had had intravenous clonidine within the past 80 hours. Just to recap the state behavioural scale, the dark green region, -3 and -2 scores, so patients that are only responsive to noxious stimuli is defined as deep sedation, And safe light sedation was the light blue scores, or the aqua scores, are -1, 0, and +1. So a patient that was responsive but generally calm and manageable on a ventilator, and that was our goal for both arms of the study. This looks a bit more complex than it is, but this is the intervention and the control group, the sedation algorithm. So the intervention group was sedated with commenced dexmedetomidine on 1 mic per kilo per hour, and opioid boluses or infusions were given at the discretion of the treating physician, and supplemental propofol was able to be used to tide over that initial period, because we didn't bolus dexmedetomidine in this study. And the aim was the SBS of -1 to +1. If sedation was excessive, then dexmedetomidine was reduced. If sedation was inadequate, then dexmedetomidine was titrated up to those doses you can see there, which are pharmacokinetically equivalent based on the clearance of dexmedetomidine at different ages. And once the opioids and dexmedetomidine was maximised, then there was the possibility of using other adjuvant sedatives, and you can see the list there, but ketamine, chloral hydrate, antihistamines, phenobarb, etc. And the last option was adding midazolam or benzodiazepine. In the control group, patients were generally commenced on midazolam, although that wasn't mandatory. And again, opioids were given at the discretion of the clinician, which opioid and how much opioids, and supplemental propofol was able to be given in that period. Once these were maximised, then we could add other adjuvant medications, and a similar list there. And then if the patients were still unable to be sedated, then dexmedetomidine or clonidine could be added on at the end. So looking at the results, these are the demographics. So the patients were well balanced in everything apart from age, and I think that was just a result of relatively small study being randomised. So we had a median age of 16 months in the dexmedetomidine group versus 3 months in the standard therapy group. Otherwise, gender, the proportion of patients post-cardiac surgery, ICU admission source and diagnostic group were all remarkably balanced between the two groups, and most importantly, risk of death using the PIM3 and PIM2 scores was almost identical between the groups. So I'll just run through the table or diagram on the right. So we screened over 2,000 patients, and just over 900 met the inclusion criteria. 655 were excluded with our extensive list of exclusion criteria. We ended up with 251 eligible patients. A lot of those patients were missed, mainly because of unavailability of RCs, but a couple of specifics in different units which didn't want to recruit certain groups of patients. And we ended up having 85 approach for consent, and 60 were randomised equally to both groups. The time to randomisation was a median of 6.25 hours. 98% of the patients that we estimated were going to be ventilated for more than 24 hours were ventilated for more than 24 hours. And we used deferred or delayed consent in 3 sites, and 18 of the 60 patients were randomised with deferred consent. 1 was revoked by the family. As I said, 40% of the patients were missed because of mainly RC unavailability, consent rate of 70%. There were a few protocol violations, 2 in the intervention group and 1 in the standard therapy group, but overall quite good result there. So looking at the clinical outcomes, the proportion of patients in the assessments in the light sedation group in the first 48 hours was significantly greater in the dexmedetomidine group. So when we included patients' assessments done at time of muscle paralysis in that first table on the left, the result was 75% against 63%. When we excluded the patients' assessments during paralysis, the result was 78% versus 70%. So a significant improvement, and the difference was most marked on the first day of enrolment, 64% versus 41%. Clinical outcomes were identical between the groups, intubation time, length of hospital stay, length of PICU stay. There were some adverse events in the dexmedetomidine group, as expected, bradycardia and hypertension, but only 1 severe adverse event. And looking at efficacy, we were worried that dexmedetomidine wouldn't be adequate to sedate children completely, but this is looking at patient sedation days. And in the dexmedetomidine group, only 14% of patient sedation days was midazolam, the addition of midazolam required for sedation. And there was slightly more propofol used in that group as well. But overall, most of the patients were sedated adequately with dexmedetomidine. So in conclusion, identification, consent and randomisation in a timely manner was achievable in this cohort, and that's borne out by a median time to randomisation of 6 hours. The cohort was well identified with 98% of the patients ventilated for more than 24 hours. Consent rate was good and deferred consent was overall successful. Goal-directed sedation with DEX was more likely to achieve targeted light sedation in the first 48 hours. It reached target-like sedation faster, and dexmedetomidine in this role was safe and efficacious with minimal severe adverse events and a low use of breakthrough sedatives. The strength of the study was multi-centre, randomised, and there was a short time to randomisation. Limitations were the sample size was small as it was a pilot study, a lot of exclusions. Patients weren't blinded. It would have been possible, but a lot more expensive to blind the study. And as far as the future goes, we've got good infrastructure for sedation trials. We can do them. It's just a matter of what type of trial design we would like to use in this setting. I'd just like to acknowledge all the contributors, Yahya Shahabi and Belinda Howe at the ANZIC RC for all the help with the study, my co-collaborator Debbie Long, and everyone who contributed at the sites, Johnny Miller and Carmel Del Zoppo, Claire Shering and Anusha Ganeshalingam, Reno Festa, and thank you.
Thanks, Johnny. Johnny, I'm looking at Johnny. Sorry. Thank you, Simon. Anyone got a question for Simon? Oh, I do have a question. I was going to ask Simon, have you changed any practices in your unit after you completed this work?
Yeah, I think there was practices were changing already. Dexmedetomidine was becoming more widely used and for longer periods. We initially used that range of 0.2 to 0.75, so now we always start at 1 mic per kilo per hour, and we use it for an unlimited time. And we generally use that as a primary sedative and then back that up with midazolam or other sedatives. So in general, practice has changed, particularly with the post-op cardiac patients.
Great. We have there's a couple down the back.
I'll actually throw a question back to you, Tina. As a retrieval service, is there a place for dexmedetomidine?
It's funny you should say that, Mary Lou. We've actually been talking about that a great deal, and yes, we will be changing to dexmedetomidine. We've just almost finished the guideline.
Thanks, Simon. In the group, the early goal-directed therapy group, there was a bit more breakthrough sedation early on. Was that throughout the duration of the study? Was it just in the early period when you were ramping up, with a half-life of about 2 hours for?
Yeah, most of the patients were given propofol early on, and that was, part of the process because of the company guidelines. We didn't bolus dexmedetomidine because that's in the sort of monogram that's released, even though pharmacokinetically, and we had a lot of discussion with Brian Anderson about this, it really should be bolused to get it up to an adequate level. So because it took a while to work, most of the patients had propofol in that early period. The breakthrough midazolam was probably spread throughout we haven't really looked at when that was used, but I would imagine that was probably spread throughout their time.
So as a follow-on, if you did this as a bigger multi-centre study, now that you've shown the feasibility, what will you do for that early period in your old?
Well, I think the use of propofol is probably ideal for that short period to attain good sedation until the dexmedetomidine kicks in. We wouldn't. I mean, a lot of the exclusion criteria we used were based on the adult spice pilot, and I think that was probably unnecessary. We use dexmedetomidine with head injured patients and with all that range of patients. So I think we probably wouldn't have such strict exclusion criteria repeating the study. But otherwise, the protocol worked better than expected. I was surprised that so little patients needed midazolam in the dexmedetomidine group.
Okay, well, can you join me in thanking?
Thank you, sir.